Welcome to the PD Exchange, the Peritoneal Dialysis podcast, where we discuss all things peritoneal dialysis. I'm your host, Dr. Nikhil Shah, a nephrologist at the University of Alberta in Edmonton, Canada. And with me is my co host and the editor in chief of PD International, Dr. Jeff Pearl, a nephrologist at St. Michael's Hospital, University of Toronto, Canada. Today, we are discussing outcomes of peritoneal dialysis for AKI treatment during COVID-19 in New York City, a multi-center study, published in the January 2023 issue of PD International. And we are very glad to have Dr. Maryann Sourial and Dr. Chen from the Division of Nephrology, Albert Einstein College of Medicine in Bronx, New York. They are the first and the senior author, respectively, of this paper. Welcome, everyone, to this episode of PD Exchange. And Jeff, take it away.
Thanks so much, Nikhil. And thank you, Dr. Sourial and Dr. Chen, for being with us. I think that, this is a really interesting topic because PD for acute kidney injury, of course, is a very well-used, and in fact, one of the first ways in which PD was used was for treatment of acute kidney injury. But of course, with the advent of continuous kidney replacement therapy and hemodialysis, it sort of fell to the wayside in many high-income countries. And in its place, we're all using CRRT for the most part in our ICUs. But I never in a million years thought that PD and AKI would make a return in the United States. I don't think anybody, 5 or 6 years ago would have predicted that in tertiary care centers in New York, PD was being used for AKI. So I think today we really, for you guys who were in the trenches doing that, we wanted you to help us set the scene for what happened, what led to this, and how you used it. And then the big question is, now that we're sort of in a much more stable place, as it were, with the pandemic, was this a one and done? Is this a one-time, we're never going to see PD used for AKI in ICUs again in high-income countries? Or are there important lessons to be learned about the potential future implementation of PD for AKI, even in non-pandemic settings that we might want to talk about? So first of all, thanks for joining us. And maybe we'll start things off. So Maryann, you were in the trenches in New York at the time when the pandemic first hit. Set the scene for us for what led to using PD for AKI.
Okay, well, thank you again for having us on this PD Exchange podcast. It was a desperate times call for desperate measures type of situation where we saw rapid influx of very ill patients with acute kidney injury, and simply because of staffing issues and the lack of supplies that we had for extracorporeal dialysis, whether it's intermittent hemodialysis or continuous modalities, whether SLED or continuous renal replacement therapy, we just needed another form of dialysis. And so PD, of course, came to mind. And we had been using PD for chronic patients in the hospital for decades. And so it became, well, why not do this for AKI as well? Especially because at the time in 2020, I don't know if you recall, but there was actually a lot of shortages in supplies in continuous renal replacement fluids. And so some hospitals were calling for making dialysate in-house for CRRT. And so instead of going down that route, because it is laden with some difficulties, including obviously making sure that the fluid is sterile, among many, many other issues, PD became the most obvious. And so for us, it became, we have a certain number of patients who are relatively stable that could get started with peritoneal dialysis. And so we started with those patients on the medical floors and then transitioned to, well, we need more. And so then we started to use peritoneal dialysis in acute kidney injury patients in the standard ICU setting, as well as all the makeshift ICUs that started to pop up just because of the sheer volume of patients that we had.
So was this a collective idea of the group, or did someone sort of come up, maybe one of the more senior nephrologists who'd sort of been in that vintage and said, guys, we got to do PD for AKI? Tell me who at your center sort of drove the bus and made that decision, or was it a group discussion?
So actually, our division chief, Dr. Michael Ross, was holding weekly meetings, sometimes more than once a week, when this started, because we quickly realized that we were going to be inundated with very sick patients who needed dialysis. And so during those meetings in the beginning, Dr. Ladan Golestani, she's one of the senior physicians in Montefiore Albert Einstein, and she has been doing peritoneal dialysis for chronic patients for years, especially in the inpatient and outpatient setting. And so we quickly, I worked with Dr. Golestani and Dr. Chen and a whole host of physicians who were familiar with peritoneal dialysis, and we quickly came up with a protocol for us and for the nurses and for the renal fellows to be able to implement this and make this a possibility in our hospital. And I think a lot of the other centers that had collaborated with us in the manuscript and the article we published had done the same thing independently. And
so you guys didn't talk together as the New York dialysis community saying, we got to do PD for AKI. This was an independent thing that happened across different hospitals in the New York area?
Yeah, it was. And we
problem?
quickly, we realized in talking to other physicians and other institutions, hey, we're all doing the same thing. Why not come up with a New York City peritoneal dialysis consortium where we talk about these things together, we share knowledge amongst each other and, collect data, because eventually this might be helpful.
That's fantastic. So tell us about the protocol. Tell us, how you started. What did you do?
Oh gosh, the first thing was figuring out how much of everything we had in storage, because that was kind of the limiting factor for intermittent hemodialysis and for the continuous modalities that we were using, whether it was SLED or CVD-HD or CVD-HDF even. And so quickly we tallied what we had. And based on that, we kind of anticipated, kind of guesstimated really what we might need in the coming weeks. And Dr. Golestani was essential for that, because we were just kind of guessing to see how much we would need to order. So she quickly ordered, peritoneal dialysate fluid. We rented some machines for cyclic peritoneal dialysis. We worked very closely with the peritoneal dialysis nurses in the pediatric department, because they're the ones who trained nurses. They trained us even to be able to properly and efficiently disconnect patients and perform peritoneal dialysis, because most of the floor nurses in the ICU nurses that were shifted from the floor to the ICU didn't really know how to do peritoneal dialysis.
Right. So maybe you'll take a step back. And you bring an important point. Even though PD for AKI isn't done very commonly in adults, it is done quite commonly in pediatric patients. Mm-hmm. And of course, maintenance PD is much more common in pediatric population. Also, mm-hmm. in some low and middle income countries, in terms of saving young lives and in the initiative to treat as many patients with AKI, PD has really played an exceptionally strong role there. So I think that it's important for our audience to understand that it's just in high income countries where it's been completely cannibalized by CKRT. To ask you that question, just maybe I'll set the stage here for people. In Einstein, if a patient came in for bypass surgery, let's say, who is a PD patient, would the ICU convert that patient to CRT under normal times, or did you continue PD in the ICUs?
It depends on who the surgeon is and how comfortable they are with their patients continuing to receive peritoneal dialysis.
Yeah.
And the prescribing nephrologist. If the prescribing nephrologist is comfortable and confident in saying, no, we can continue peritoneal dialysis and, we can take appropriate measures to do X, Y, and Z, peri-op time, then usually we can sort of keep them on, again, unless they're terribly volume overloaded and, they're ventilated or end up on ECMO or something, then obviously we end up changing modalities. But oftentimes, if we can, we keep them on peritoneal dialysis.
But you're saying that's physician dependent?
Yes. Oftentimes I find some of the surgeons and the non-nephrology staff are a bit uncomfortable with continuing peritoneal dialysis in very acutely ill patients or patients who are peri-op, especially for major surgeries like cardiac surgery.
So it's us as a nephrologist that really need to be comfortable and provide that support and education. Because I always say, just like I don't tell them whether to do a bypass or PCI, they shouldn't tell us whether to do hemo or PD, right?
I firmly believe that. That was one of the
Okay.
things that we were.
The reason I bring all this up is because the culture wasn't like PD rah 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 before acute kidney injury. So you were definitely like, you know, if you had established PD in the ICU and you were doing that even for maintenance patients, conceivably the transition to PD for AKI might be a bit easier. But this is not a pro PD environment we're talking about for the in acute therapies.
For the most part, right.
Right. Okay. So you order the solution, you get the cyclers, you speak to the pediatric nurses who are going to be tremendous resources to you. Tell me about the catheter insertion and patient selection. Tell us how you went about with those two activities.
Yeah. So actually, I have to give a great shout out and thanks to the transplant surgery department and the interventional radiology department at Montefiore. They did a really great job. We heavily relied on Dr. Juan Roca, Dr. Jay Graham to place these actually bedside catheters for patients who are in the ICU who are ventilated. They came bedside and performed Tankoff catheter insertions. For patients who are a bit more stable, we were actually able to send them to the IR department who, believe it or not, had previously not done peritoneal dialysis catheter insertions. They trained and they quickly became a huge asset to us to be able to perform these off-unit procedures for our more stable patients so that we can get them started on dialysis. Otherwise, it was going to be a waiting game to see when Dr. Roca and Dr. Graham were able to place these Tankoffs.
Had they done them bedside before?
Dr. Roca and Dr. Graham, I believe they had in the ICU setting. Yes, they're persistently working with our team and in the ICU team to troubleshoot any catheters and exchange catheters, and if patients need an exchange. And so this wasn't terribly new for them. I think the IR department being involved was a bit new for us, for Montefiore.
And they had never put them in before, the IR department. They learned.
No, and they did a great job.
Wow, that's unbelievable. And okay, so tell us about patient selection. Like, who did you decide? You said first you went to the ward. So were these patients with established AKI requiring dialysis or de novo AKI on the inpatient ward? Tell us about some of the things that you guys thought about and how you selected your candidates.
So I think, again, it was in the beginning very much nephrologist dependent. And so I think the majority of us would kind of evaluate the patient. Most of the patients that we had seen were de novo AKI due to COVID. At bedside, the discussion with the patient would be, these are the options for dialysis. We're going to try to start with peritoneal dialysis and see, how you tolerate peritoneal dialysis.
One of the first questions I had actually in this was, you all these patients were not ICU patients. So you started off with patients right before on the wards, and you started having these conversations right then. How did the patients take it? Because was it kind of served as this is the only option they have, or was there a discussion like, desperate times, desperate measures sort of a discussion? I mean, from a patient perspective, it is challenging.
I think for the majority of our patients, especially in the beginning, we had given them the option of peritoneal versus, intermittent hemodialysis. And when we present the information, we go through, as anyone would with informed consent, the risks, the benefits, and the alternatives. And so the alternative to intermittent hemo was PD and vice versa. And we went through both risks and benefits for both types of modalities. And from then on, it really depended on the patient body habitus, whether they had had prior abdominal surgery, the usual thought process for and indications or contraindications, though they're little, for starting someone on peritoneal dialysis versus intermittent.
But did you not have to tell patients we don't have hemo, it's PD or nothing?
That came later, not in the beginning.
Right.
In the
Okay.
beginning, we were trying to give patients the option because we had the option,
Right.
albeit limited depending on the day. But oftentimes, if we had the option, we presented this option to the patients. But again, with staff shortages, nurses were out sick, and our hemodialysis unit was inundated as it was with chronic patients, and now we're having a lot of acute patients too who are sick. So if we just didn't have intermittent hemo, we didn't have it. And so peritoneal dialysis was the only option for these patients.
Okay. Question for Dr. Chen. You had these discussions with the patients and kind of moved on. Was it a very sort of a difficult, especially when the patient's condition started deteriorating, right? And the patient had to move to the ICU. Like you're discussing this on the ward, the catheterization PD has started, and now the patient is worsening. Making the call to move to the patient into the ICU, continuing PD, switching to hemodialysis. How did all this thought process set the stage for us? This is fascinating.
Oh, I think Maryann has to answer that question. We actually are on different campus, and my campus don't have most PD patients are coming from where Maryann works. But yes.
Okay.
So I have to. She's much more frontline than me, and she's more expert in peritoneal dialysis.
We were all in it together. It was rough time.
All right, Maryann, you answer this question.
So if we were able to keep the patients who had started on peritoneal dialysis, we certainly did. Okay. Oftentimes, and as you saw in the manuscript in the article, we did have to transition or supplement rather patients who were already on peritoneal dialysis with either intermittent hemo or some continuous modality, be it SLED or CKRT. And oftentimes that was a day-to-day decision, believe it or not. If one day we came in and the patient's potassium was 7.5, that changed a little bit how we chose their dialysis for the day versus, if they were not in the ICU for an electrolyte abnormality, if they were not terribly fluid overloaded and needed, volumes and volumes of fluid removed, then we kept them on peritoneal dialysis. Certainly that was the goal, is to keep them on that modality so that we can reserve our resources for really dire cases.
Mm-hmm. We've all seen those pictures from New York, right? When the patient is in the ICU and on peritoneal dialysis and these long tubes sneaking out of the room. Is that what you also experienced? Is that something that you guys did too?
Yeah, I think for the most part, for patients who are on peritoneal dialysis, we either had a cycler in the room or we were having to go in and out of the room because there was just too much coming out of the room. So many tubes, so many things were going in and out, and really it was too much. We couldn't even close the doors for some of these patients, right? So we were having to go in there and perform the exchanges ourselves, and the nurses, the renal fellows, we were all having to go.
Everybody pitched in here. It was not just the nurses who were doing this. So everybody got a crash course on doing PD and then AKI ICU setting. That is.
So were you doing mostly APD on the machine and doing sort of low volume APD, or were you doing manual exchanges?
I think in the beginning we were doing more manual exchanges, and then as we got a few rentals, we were able to switch some patients to APD. And for us at Montefiore, and this obviously is going to vary depending on the hospital system, but for us, we were able to keep certain units on APD and certain patients on APD depending on how well they did. If they were not having too many alarms, if the nurses were comfortable troubleshooting the alarms and helping us out as nephrologists, then we kept the patient on APD. If for whatever reason they were alarming a lot, retaining a lot of volume, the nurses were overwhelmed and couldn't answer the cycler when it alarmed, then we were ending up doing more manual exchanges so we can troubleshoot as we went.
And who was doing the manual exchanges?
Oh, everyone. Nurses, attending nephrologists, renal fellows, any residents that we had on service with us. And actually, I have to say, there were a couple of residents who were not on service with us who had volunteered to learn how to do manual dialysis.
So you had physicians doing PD exchanges on admitted patients with acute kidney injury.
Yeah, many of us, actually, a good majority of us
That is
volunteered.
unbelievable. I think that's unbelievable. Really?
I have to say,
100%.
our department was really great about if it was a weekend and we were just really super busy, people would come in voluntarily and perform exchanges. They would do a couple of exchanges in the morning and then they would go. And then the next person would come help out. That's how we
Wow.
ran.
So you had like an assisted PD program for inpatients with AKI, where the assistants were the physicians, fellows, trainees doing that. Did you have wet contaminations?
That we're aware of. We did actually try to collect data on that.
Yeah.
And thankfully we didn't have that many. I think we only had a couple of contaminations.
Okay.
And actually one of them wasn't abdominal. One of them was something bacterial that was systemic and became abdominal.
Oh, right. And then for the APD setup, who set up the APD?
Big machines.
So for APD, actually, the physicians, the attending physicians did. We were
Set it up.
Oh, physicians did it?
Yeah,
Oh,
we went
wow.
around and we were the ones who did it. Our nurses were only trained in manual PD, and we just didn't have time to go through and train all the nurses.
So before COVID, the landscape at your center, which is not dissimilar from other centers in the US, is that only admitted patients were only supported with manual exchanges? Is that?
Yeah, unfortunately,
Inpatient
we didn't have the training
inpatient
available.
APD was not something that was supported for inpatients before.
Not frequently. We had a couple of cyclers that were available, and it very much depended on the nurse that was covering the patient, whether they were comfortable managing APD patients or not.
And who are those nurses at your center that are doing who gets trained to do that?
So we had dedicated floors for peritoneal dialysis patients to be admitted to. If they were on telemetry or if it was a general medical ward, there were certain floors that the patients went to where the nurses were trained in peritoneal dialysis. All the nurses were trained in manual exchanges. Now, only a few of them were trained for APD. And so if they knew how to manage APD patients, we kept the patients on cyclers. But most of them, I would say maybe 90% of them, were more comfortable doing manual exchanges. And so most of the time we did manual. And if a patient was on a cycler and did get APD during this pandemic time, then the attending physicians were the ones who were going around and connecting patients. We did train, obviously, the fellows, and we had some really great nurse practitioners come help us out. And if we had the time, we trained them too, but it was more all hands on deck kind of situation. So
without going into details about the vendor, because I don't want to, did you get support, or were you allowed to facilitate support from the vendor to come in with training and education in this very dire situation?
So the vendors were very helpful in expediting delivery of supplies. In terms of training, we just did our in-house training ourselves. So any nurses, fellows, attendings who had volunteered, who had never done this before, including myself, actually, I had never done APD for patients.
Right.
I'd never physically connected them. And so that training came from our very, very experienced nurses in hospital who were doing this for predominantly pediatric patients, actually.
Right. So they were the point people to train you all. And if you guys had questions, that's who you would ask about the cycler.
Yep.
Wow. Wonderful. Can I ask another question about the catheters? Because it's still, did you see complications? Like, this is acute PD, right? Mm-hmm. You have fresh catheters put in by not people who are putting them often, and they're sick patients. So what kind of complications did you see?
So there were a couple of times where obviously we were putting these catheters in and using them right away. And so there were a few times where we had some leaks. And so we had to kind of troubleshoot and work around that. These are patients who were not getting omentectomies. And so there were a couple of times where, the omentum would wrap around the catheters, and then our very experienced transplant surgeons would come in and help us out in repositioning the catheters and troubleshooting how we can use the catheters, because we really needed it. I think we had discussed, there was a couple of times where there was just failure to remove a lot of volume, or patients were terribly acidemic or hyperkalemic, and just peritoneal dialysis, even though we were performing peritoneal dialysis anywhere between 12 hours to 24 hours, it was sometimes nonstop for these patients because they just had so many metabolic derangements and
Right.
volume overload. If they couldn't do well with peritoneal dialysis, we had to switch them. And so oftentimes they were either supplemented with intermittent hemodialysis or a continuous modality for, about 12 to 16 hours, and then transition back to peritoneal. Or if their metabolic derangements and volume overload were that severe, we just switched them over.
You had patients prone on PD or none?
We did. If we were able to keep them on peritoneal dialysis while they were prone and we didn't have any alarms going off, or again, terrible fluid overload or terrible leakage from the peritoneal dialysis site, we kept them as best as we can. Yeah. It wasn't frequent, unfortunately, but we did the best we could of the circumstances.
So you also had a bunch of people who received intermittent hemodialysis around the same time. Was there a thought that, you could transition some of them to peritoneal dialysis?
Yeah, so there were a couple of patients who I think more at Dr. Chen's institution who were getting intermittent hemo that were transitioned to PD because we said, oh, you know what, they're stable enough that we can switch them to another modality and just see how they do, so that we can offload the hemodialysis and the CKRT. Yeah. But we did do that at our center, at the Moses campus as well. Yeah.
I've got a question. Two things. So taking a step back here, this was all happening, by the seat of your pants, right, as it was happening. I've got a few important questions. Do these newly found skills in interventional radiologists get used now to start urgent start PD, or for, let's say, patients who perhaps are unable to undergo a surgical catheter? Have your radiologists continued to place catheters for your patients?
I think not in the past year. I don't think they really had done them since the time of the pandemic.
Okay.
Hey, do you remember? I don't think there's been that many. No.
No, and these a while we haven't been putting in PD cap. Yeah, no.
Okay. Next question. I'm just talking about sort of any lasting effects now in your practice. Is the ICU more likely to continue maintenance PD in admitted patients, do you think, after this? Has the comfort improved? Or is it back to the way you guys were before for the most part?
I think, like I said, at the Moses campus where I primarily practice or was practicing, they are much more comfortable because they saw firsthand that, hey, this works. Why not keep a patient on it? And so they're much more comfortable and much more likely if we say, let's keep a patient on PD who's chronically on PD, or if we, for whatever reason, choose to start the patient on acute PD, they're much more comfortable keeping them on than they used to be, definitely.
And then, so are you using acute PD now in non-COVID patients? Is there a role for it? So, and how has anything changed at your center in terms of lessons learned from the pandemic to use acute PD even now?
So I'm going to answer for myself, and Wei obviously can answer for Weiler campus. I'm actually no longer with Montefiore. We moved. My husband got another job. So as of the last time that I was at the Moses campus, what we were trying to do actually was to tabulate the number of patients that we were having who had acute kidney injury in the hospital, and see how many of them could be on peritoneal dialysis, so that we can rent more machines, rent more cyclers. But in order to do that, we have to justify the need for them. And so we really needed to tabulate how many patients we see who have AKI who could benefit from continuing this acute PD program. And I think we were headed in that direction, that, we were seeing a lot of patients with AKI who could be on acute PD and don't necessarily need to be on hemodialysis. And so we just needed the numbers to train the nurses, rent the machines, and continue the program. And like I said, when I left Montefiore, that was where we were headed. Yeah.
And where are you now?
Pardon me?
Where are you now?
I'm actually in California.
Where?
Um,
Where?
I'm not practicing at the moment. I'm waiting for my California license still.
Okay. So
But
somewhere in California, we're expecting an acute PD program for
I
AKI.
hope so.
Okay.
I hope so.
Uh,
I'm actually in the Central Valley, and believe it or not, there's a lot of really sick patients here. So why
right.
not?
So tell us who you would consider. So say you were back, let's say you were back there. Who would you say, let's try PD for this patient? Tell us the type of patient with AKI you think might be amenable to PD in non-COVID circumstances.
Actually, I'm a firm believer that most AKI patients could be on APD. There's very few contraindications in the literature for why you wouldn't choose PD. And so, body habitus, prior abdominal surgeries, if they have severe electrolyte abnormalities that just need, to be addressed emergently, if they have severe volume overload where, you need liters and liters off, or if they're on ECMO, it's a little
So
less
exceptionally
likely.
hemodynamic, exceptionally metabolically challenged, exceptional hemodynamic circumstances like cardiopulmonary circumstances like ECMO, perhaps maybe even extremes of, very, very extremely large body habitus might not be ideal.
Right.
But, as we thought about it and thought about this question, because I think a lot of people are learning about the possibility of doing this more long term, not under crisis conditions. In my mind, like the cardiorenal population might be very amenable. Patients, who've had cardiac surgery. It used to be, some of my colleagues have told me that some of the cardiac surgeons would put PD catheters in the OR when they felt that a case was at high risk for acute kidney injury in the quote unquote olden days. And this was quite common practice, which to me makes sense because if you've got a fresh valve, you can avoid access related bacteremia with a hemo line. Anticoagulation issues become challenging. And so I think the cardiorenal cardiac population might be one that I could see a real value to being a little bit more proactive about studying this issue, about the utility for PD for AKI. So I'd like to see personally some development in that domain. And I was going to ask you, so we do it. Who do you see? I mean, maybe fellows will come in to do PD exchanges under COVID conditions, but clearly that's not sustainable for a maintenance program. For maintenance PD for AKI, who do you see running the show in the ICU? If someone's going to ask you, do you see that the ICU nurses are learning? Do you see that subspecialty nurses come in to set the machine up and troubleshoot overnight? How do you best see, and maybe there's not a one-size-fits-all approach, but from what you experienced, how do you see models of care for a more maintenance program?
So it's a really great question. And that's part of the challenge of continuing this APD program post-COVID, pandemic times. And that's one of the things we were trying to address, again, prior to my moving away. And so really, like you said, it's not really a straight answer. It really depends on the resources. And unfortunately, we are seeing staff shortages in the nursing staff. And so if it's available, I think it makes sense that the nurses who are, the primary nurses for these patients are trained, and a lot of them were trained in manual exchanges, that they also train in the APD system as well, and can continue. If, however, we continue to have nursing shortages, then it may be best if maybe some of the companies could support us and send out staff to educate, to provide supplemental care for these patients, machines beeping.
But you could see a model where ICU nurses, just like some of them manage CKRT, would manage the cycler or PD exchanges.
I do, yeah.
Okay. And then my next question is, I think one of the things that is very impressive is how you've mobilized this pretty quickly. I think in other parts of the world, be it a pandemic, be it a natural disaster with loss of electricity or water supply or other issues, there could be a role to fast mobilize PD for AKI. I just wonder if, you feel it might be a missed opportunity for those people who gain that skill set, the radiologists to place catheters and the surgeons, that just having a maintenance PD for AKI program would at least allow you guys to maintain some competency in it that if you had to ramp this up again, it would be a lot easier with some of those infrastructure and resources in place. So another sort of argument to continue PD for AKI in my mind, and I wanted to get your thoughts, is if it happened once, it could happen again. May not be a pandemic, hopefully, God willing, may not be something else, but look what happened in New York City, that has the best and brightest of everything. In New York City, you guys had to revert to PD for AKI. It could happen again anywhere. So I just think having that competency might, build some resiliency against this kind of situation in the future. So what are your thoughts about that?
Oh, I certainly agree with you. We don't really have to look too far. Out here in California, during these massive rainstorms and flooding, a lot of people are losing electricity. A lot of people don't have access to clean water. Though it's raining and there's a lot of flooding, it's not clean water. So what do you do in those situations? And so it makes sense to me that we continue a maintenance program at Montefiore and at other hospitals in New York City where we've gained this knowledge already. In the event that this happens again, we don't, again, last year when Texas and Louisiana and Oklahoma and that area had terrible snowstorms and, power outages, a lot of patients died. A lot of patients didn't get the dialysis they needed. And if we had the resources to perform acute PD in these patients, emergently put in catheters and get them on PD, potentially there might have been some lives saved. And hopefully we can do this in the future in disaster type situations, or not even disasters, just continue using peritoneal dialysis because it's a great modality. And it's efficient and it's cheap and super quick to learn.
I'm glad you share that. But the missing link here, and I think the thing that everybody has to realize, is expertise and comfort and expertise. So we have to keep maintaining that and not let this be a missed opportunity to continue to sustain comfort and expertise. And that's kind of what I hope that some of the New York area hospitals, from somebody from the outside who's just overwhelmed with just sheer, I'm in awe of what happened, not to make that a missed opportunity to continue to sustain the expertise, be it in catheter placement, in acute prescriptions, in developing a PD program. So this is the jumping off point, I think, for a real opportunity to study this issue and implement it. And I was going to ask you one more question I had for you is, what's your biggest lesson learned? So let's say we could rewind the clock all over again, that this pandemic is going to happen and you're going to be faced with this. What do you think you wish you guys had done differently in the delivery of PD for AKI that is an important lesson learned moving forward if this ever happened again?
Oh, goodness. That's a really good question. I guess probably training more people to do this, because it was
so it's the human factor. It's getting comfort. It's making sure there's that critical mass of people who know how to deliver this therapy.
Yeah. I mean, some of us had, I don't want to name names, but many of our department just continued working for 30, 35 days straight, maybe with a couple of days off in between, just to have a day off to see your family. But really it was a lot, because there just wasn't enough people to be able to do this. And so everyone volunteered and it was amazing, but really we need more people to learn how to do this.
Just want to add that the New York City Peritoneal Dialysis Consortium is still ongoing, and it's being led by Dr. Barry, and we are having monthly meetings to discuss journal club, to share our experience throughout New York City, and every time we invite the trainees to come and join us. So we're hoping that this will be a starting point to provide more ongoing education to our trainees. And then just something that Dr. Pearl said about what if it happened again. Well, just you may or may not be aware of, just last week we had a nursing strike for 3 days in Montefiore. There was not enough nurses to do hemodialysis, especially on the first day of the strike when the travel nurses are still on the way. We did. I actually got a crash course on CKRT, and I had to run CKRT for one night for ICU patient. And on the same night, there was issues with the PD nurses as well. And again, Dr. Gorosani stepped in and trained our fellows to perform manual exchange for about a day or two. Luckily, only last 3 days, but it could have been worse.
This was exactly my question.
yeah, we need to build this resiliency in the system. And again, seems like it's creeped up earlier than you guys might have thought, again, because of a human resources issue.
Right.
I want to say that, and I want to apologize, Maryann, and we're hearing the Einstein experience at Montefiore. There's clearly other centers in New York. I think this is a great, this was a great podcast, and Nikhil, I learned a lot about this and just inspired by what you guys did. I think the New York PD community really needs to have ongoing discussions and share these experiences with the PD community, because they're only through the sharing these experiences are we going to be able to elicit change. And again, people are probably, not as shell-shocked as you guys, because it wasn't in their backyard that this was all going down, but we're all at risk for something, to happen. And again, I think it affirms a really strong role that PD for acute kidney injury can have. And we all need to develop better education and tools and resources to be able to implement it.
So first of all, thank you, both of you,
Yeah, thank you.
for coming on the show and sharing this experience.
us.
We cannot even imagine what you guys must have gone through in that phase, right? That must have been crazy. But thank you, both of you. And that's a wrap for today's episode. Link for the paper is in the episode details. And please reach out to us on social media or email for any comments and suggestions. Our Twitter handles and email IDs are in the episode details as well. Hope you all enjoyed the show. This is Jeff and Nikhil signing off. Until the next PD Exchange, take care. Thank you.